Assalamualaikum. My name is Dr. Amjad, representing Medical Unit 4. Today's topic is very important regarding liver disorders, causes of cirrhosis in young people, young patients, and these are inherited liver disorders like hereditary hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiencies with various presentations which I will discuss later on. First of all, hereditary hemochromatosis. Very important university question. What does it mean? Increased total body iron depositing in various organs in the body in the form of hemosiderosis, hemosiderin, sorry. The primary disease of iron deposition is hereditary hemochromatosis, in which the absorption due to mutation in gene resulting in genetic disorder, there will be increased absorption of daily iron in the form of hemosiderin, while its excretion will remain the same. So it will accumulate in various organs. It's autosomal recessive disorder, means the both parents and their genes should be abnormal for transmitting the disease. So what are the clinical features? Depending upon the various organ involvement, the clinical features will be like that. The most common involvements is in the liver, followed by pancreas, skin, heart, pituitary, and joints. As I said earlier, that is common cause of cirrhosis in young people. Age of presentation in men is 40 and bit late in women due to pregnancy, iron and loss of iron in menstruation. So in women it presents late. What are non-specific? These are fatigue and lethargy. So fatigue is already common in our community, so that's why you can consider there is no non-specific symptoms except fatigue. If the liver is enlarged, this is the most common symptoms of liver involvement is hepatomegaly. 95% of the patient in advanced disease has liver disease, followed by cirrhosis. Hepatocellular carcinoma is common in patients who have involved the liver. Next is pancreas development. So if this iron deposition leads to destruction of pancreatic islet cells, then this type of diabetes will be like type 1 diabetes mellitus. As you know, there are 4 types: type 1 diabetes mellitus, type 2 diabetes mellitus, gestational diabetes mellitus, and other types. Hemochromatosis, pancreas involvement in hemochromatosis comes under other types. So it may present with like type 2 diabetes. If there is liver involvement, there will be insulin resistance, so it will present like type 2 diabetes mellitus. So if iron deposition leads to total destruction of pancreatic islet cells, this will behave like type 1 diabetes mellitus. And the treatment will be like involvement. If only liver involved and leading to increased insulin resistance, so we will treat like type 2 diabetes mellitus. And if that patient doesn't respond to oral hypoglycemics, so it means that there is failure of beta cells leading to type 1 diabetes mellitus, so we will shift patients to insulin. And skin involvement: bronze color due to combination of slate gray as a result of iron and brown due to melanin. That's why diabetes in hemochromatosis is called bronze diabetes. And where are the skin most commonly involved, and their color is in exposed parts like axilla, groin, and genitalia. It will be generalized, and if the joint involved, the most common joint involvement is the second and third metacarpophalangeal joints. The patient may present with joint pain and chondrocalcinosis. So if patients have joint pain with some skin color change and diabetes and liver involvement, you can suspect presence of hemochromatosis. The next is heart involvement. Patient may present with heart failure and cardiomyopathy. If the pituitary is involved, there will be loss of libido, testicular atrophy, and impotence. Again, due to iron deposition in. There are some rare manifestations of hypoadrenalism, hypothyroidism, hypoparathyroidism. This is the skin color, bronze color of skin. How we will diagnose or suspect patient with having hemochromatosis is the family history. As this is autosomal recessive disorders, we will ask for other family members involvement, increase iron saturation or serum ferritin, as well as symptoms as the skin involved. If you see the patient has bronze color or skin pigmentations, and patient have diabetes, and patient have changes of cirrhosis, signs and symptoms of cirrhosis or hepatomegaly, you will suspect presence of hemochromatosis. So if in this disease, transparent saturation will be more than 45% with elevated serum ferritin and serum iron. MRI of liver is highly specific for its to see iron deposition, and liver biopsy is the gold standard test. So this is hepatic iron index. If it is more than 1.9, it will suggest presence of hereditary hemochromatosis. Genetic testing, who have first degree family members, we can have HFE testing and iron studies. And definitely if we want to see the genetic change, we will go for HFE testing. So what is treatment? Obviously, if iron is overloaded in the body causing symptoms, we will reduce its amount in the body by any way. So first of all, conservative, avoid the foods which are rich in iron like alcohol, vitamin C, and supplemental iron. Then is symptomatic treatment. Suppose if patient presents with cirrhosis, signs and symptoms of cirrhosis, the treatment is same as patient with cirrhosis of other causes like hepatitis C or other causes. So if patient presents with ascites, you will give diuretics and aldactone. Patient presents with constipation, give them lactulose, and same treatment of other symptoms. Same like that if patient presents with diabetes, so it's because it's type 1 diabetes, so you will give insulin. Then is specific treatment, that is phlebotomy, weekly or twice weekly depending upon symptoms and iron overload. 250 to 500 ml blood is removed. At every 500 blood we remove 250 to 250 milligram of iron. So our target is to keep serum ferritin levels below 50 microgram per liter, and once this target is achieved, we will go for maintenance phlebotomy every 2 to 3 monthly. Monitoring is with hematocrit and serum. Then is chelation therapy in patients who have severe anemia where phlebotomy is not possible, or secondary iron overload like in thalassemia. This is deferoxamine. So some studies proves that proton pump inhibitors which decrease iron uptake is beneficial, and then management of cardiac failure, hepatic failure, and diabetes. The ultimate treatment of cirrhosis of any cause is liver transplant. So treatment can't reverse cirrhosis, diabetes, and arthropathy, while it will reverse cardiomyopathy and skin discoloration. Key points for hemochromatosis: if the patients have family history of early cirrhosis or cirrhosis in young patients who don't have hepatitis B or C profile that is negative and no other cause is identified, and you find some skin pigmentations, you have early cirrhosis with diabetes, you have cirrhosis with this joint involvement, you will consider for hemochromatosis. The next is Wilson disease, autosomal recessive disorders. In this, copper absorption is more in small intestine, while decreased excretion by the liver. So excess copper that deposits in liver, brain, cornea and kidney, causing symptoms depending on the organ involvement. So if the young patient of cirrhosis presents with neurological disorders or psychotic disorders, you will consider Wilson disease. Age of presentation is 5 to 45 years of age. Usually patients have early symptoms are vague and non-specific like lethargy, anorexia, abdominal pain. So this is very important that if patients early age presents with liver disease, while adults they presents with neuropsychiatric disorders. So symptoms: if liver is involved, there may be acute hepatitis, chronic liver disease leading to cirrhosis and complications of cirrhosis, acute liver failure. So whom you will consider? Wilson disease should be considered in a patient under age of 40 with liver disease and neurological disorders or psychiatric disorders, recurrent hepatitis where there is no cause identified, and liver disease with hemolysis. If you find anemia, hemolytic anemia in patient with cirrhosis, suspect Wilson disease. So what are the neurological features? Neuropsychiatric, sorry, that is dysarthria, dysphagia, ataxia, Parkinsonism-like features, movement disorders, dementia, and behavioral changes like psychosis and depression. So other involvement, as I said, that hemolytic anemia is a common scenario of patient if have cirrhosis with hemolytic anemia, suspect Wilson disease. So what is this? Copper deposits in decimate membranes. It can be seen in advanced diseases in with naked eyes, while in early slit lamp required in most patients. 50 to 60% of the patients with liver involvement have Kayser-Fleischer ring, while 95% of the patients who have neurological involvement, Kayser-Fleischer ring can be seen. What are other causes? They may be cholestasis of any cause, primary biliary cirrhosis. One of the most characteristic feature of Wilson disease is that no two patients, even within a family, are ever quite alike. In a family even, they will present in different ways. So this is a very characteristic feature of in family diagnosis of Wilson disease. In an individual, you will screen the other peoples after every 3 to 5 years. Diagnosis is by liver biopsy, and determination of hepatic copper organ is the gold standard. We just do hepatic copper concentration. If that is elevated with low ceruloplasmin, high 24-hour urine copper, and if we find KF ring, we don't need liver biopsy. In highly suspected cases where these are two of them are normal, we will go for liver biopsy after taking consent from the patient. So In MRI shows brain involvement in basal ganglia, cerebral white matter, midbrain, pons, and cerebellum are the most common. So what is treatment? Again, restriction of dietary copper. They are organ foods, nuts, chocolates, and mushrooms. D-penicillamine is the treatment if in patients, along with trientine, zinc, tetrathiomolybdate is the neurological environment is more, and if cirrhosis develops, liver transplantation is the treatment. What is key points for Wilson disease? If young patient with cirrhosis or acute hepatitis with neuropsychiatric involvement, or young patient with cirrhosis, acute hepatitis, or hemolytic anemia, you should suspect presence of Wilson disease along with family history. The next is same as the next cause of cirrhosis in young patient is alpha-1 antitrypsin deficiency. Now, if patients have liver and lung involvement, the common etiology is alpha-1 antitrypsin deficiency in young. So again, this is autosomal recessive disease due to low serum level of alpha-1 antitrypsin and commonly presents with liver disease as hepatitis, jaundice, as cirrhosis, and emphysema if the lung. So alpha-1 antitrypsin is functioning as a protein inhibitor which inhibits protease release at sites of inflammation. So it is synthesized mainly by liver cells, and alpha-1 antitrypsin is an acute phase plasma glycoprotein. Its serum level elevated during infections and other accumulation of misfolded AAT in hepatocytes results in formation of cytoplasmic inclusions and apoptosis. In lung, absent or low circulatory results in unopposed leukocyte protease activity during any inflammatory process. So destruction of connective tissue causes emphysema. Smoking is an other risk factor. So what are signs and symptoms? Jaundice, dyspnea, cough, recurrent pulmonary infections, tiredness. So key point, patients who have lung and liver involvement and family history suspect alpha-1 antitrypsin deficiency. Diagnosis by chest x-ray and spirometry. On chest x-ray you will find findings of emphysema, serum alpha antitrypsin level, and this x-ray is showing emphysema, long tubular heart, low-lying flat diaphragms, wide horizontal intercostal spaces, and hyperlucent lungs. This CT chest also showing emphysema of both. So what is treatment? In the if the lung is involved, avoid cigarette smoking and infusion of AAT from pooled human plasma. Liver mainly symptomatic, and if cirrhosis, liver transplantation. Thank you very much.